joining us today. We're holding this hearing virtually in compliance with the regulations for remote committee hearings pursuant to House Resolution 8. This authority has allowed us to continue to do our work while keeping our staff, families, witnesses, and broader communities safe. Before we turn to today's important topic, I do want to remind members and our witnesses of a few procedures that apply in this unique hearing. First, consistent with regulations, the committee will keep microphones muted to limit background noise. Members are responsible for unmuting themselves when they seek recognition or when they are recognized for their 5 minutes. Members and witnesses must have their cameras on when present in the hearing. If you need to step away from the proceeding, please turn off the camera and audio rather than logging out. Finally, understand we'll have some votes this afternoon in the House. My current plan is to continue as best we can with our proceedings and avoid recessing. If your time for questioning occurs, be assured that I'll come back to you, give you an opportunity to question, as I will any of our committee colleagues who join us, who are not members of the subcommittee, who will question after subcommittee members. Thanks to all of you for your patience as we navigate this technology. So a few words as we get started. From the earliest days of this pandemic, people with disabilities have paid a high price, borne a heavy burden, and endured untold losses. Our hearing today examines how the pandemic has exacerbated longstanding barriers to healthcare access and health disparities faced by people with disabilities, and will highlight some critical avenues for reform, especially stopping the wait, the outrageous wait for those who, after being determined by Social Security to be disabled, must wait a long 2 years before they can obtain Medicare coverage for which they have already qualified. Let's remember the extreme vulnerability of this population, who can only qualify for Social Security disability insurance if they have a condition that is so debilitating that they're unable to work for at least a year. More appropriately described, I think, as suffering periods, an estimated 1.6 million Americans are currently stuck in this Medicare waiting period gap. And in 2018 alone, about 56,000 individuals died while they were waiting for their Medicare coverage. As one constituent described to me, the system treats applicants like, quote, they have to prove their innocence. I think it's essential that we end this systemic bias and stop the wait, as my bipartisan legislation with Representative Fitzpatrick, Senator Casey, and 75 House co-sponsors would do. In the final days of the last Congress, the 116th, we did stop the wait for those suffering with ALS or Lou Gehrig's disease, as I think it's more commonly known. Another pending bill proposes to stop the wait in this Congress for those suffering from metastatic breast cancer. And our colleague Bill Pascrell proposes to stop the wait for Huntington's disease. While each of these individual specific disease measures is worthy and has my support, I believe that this Congress must do more than just chip away at the problem disease by disease. All of those who are caught up in these suffering periods deserve genuine relief. No one with conditions severe enough to qualify for disability should be without health insurance. Social Security is not truly providing health care security until all individuals with qualifying disability insurance have guaranteed access to Medicare coverage. This arbitrary wait was no doubt established to contain cost, but it really only shifts the cost to the vulnerable. And our Stop the Wait Act has become all the more important as more Americans are suffering from long-term COVID, a condition that represents the largest new entrant to the disability community in modern history. The pandemic has been described as a mass disabling event because of the vast number of people who, after contracting COVID, are now newly disabled or chronically ill. I applaud our colleague Don Beyer for his efforts to fully fund scientific research into the effects of long-term COVID. it is more urgent than ever to address the many healthcare challenges that we face with disabled patients. I will welcome to the hearing shortly Dr. Monica Verduzco Gutierrez, a stroke and brain injury rehab physician and the head of the long COVID clinic based at UT Health San Antonio and the University Health System. She will explain the range of symptoms of long COVID and what it means to her patients and the supports that they need. We'll also be hearing from Liza Fisher, who will share her moving experience with long COVID and the Medicare waiting period. Stories like hers are why I authored the Stop the Wait Act. Liza has also been denied access to health care by the unfortunate circumstance of state Republican leaders in places like Texas refusing to accept federal dollars to expand Medicaid eligibility. Another very important policy to examine in connection with today's hearing is the promise of telehealth, telemedicine. Expanded access to it permitted by emergency waivers during the pandemic has really transformed healthcare delivery. For patients with disabilities, this has removed transportation barriers, enabled easier access to specialists, and helped individuals remain safe during the pandemic. In explaining the importance of telehealth, Nicole and Cody are two individuals, two Texans who've contacted me and said, people are afraid of the clinics, of the emergency room, even of their doctor's private suite. It's downright scary for an immunocompromised patient and her caregiver to set foot on medical premises. Well, telehealth has responded to that, and it has helped so many people, particularly the immunocompromised, to connect to their physicians safely. However, as we will hear from Dr. Rupa Valdez, the design of telehealth platforms, removing coverage restrictions, and access to broadband and smartphones are all essential to ensuring truly equitable benefits. During the previous hearing last year before this subcommittee, we discussed how best to prevent a telehealth cliff when the emergency waivers expire. Fortunately, they've now been extended to March, but we may face a cliff again later this year. And we know the importance of building a system that promotes equity, certainty, expands access, and ensures quality of care. Today, we will continue the telehealth conversation and consider the policy proposals for expanding telehealth, such as the Bipartisan Telehealth Extension Act that I've introduced with Representatives Thompson, Kelly, Schweikert, Buchanan, and several others on our committee. I hope this will soon move forward with a markup in our full committee. The pragmatic approach that we take permanently removes the onerous site-based and geographic restrictions that have a disproportionate impact on patients with disabilities. We also provide a temporary 2-year extension of the broad range of services permitted with telehealth under the emergency waivers, providing time for further study of the quality of care and what additional policies are needed to ensure platforms do not create new disparities. And at the same time, we seek to avoid any fraud that might be exploited through telehealth. Healthcare access for disabled people is, of course, not new as a problem, as an untenable state that existed before the pandemic. As one Texan contacted me about recently, he said, quote, "I want to live independently. People with disabilities have that right. We may need accommodations, but we deserve the freedom of independent living." And I couldn't agree more. Bethany Lilly is here to describe some of the pre-pandemic challenges, including difficulties obtaining and maintaining insurance coverage, underinvestment in home and community-based services, challenges getting to and from appointments, inaccessible facilities and equipment, stigma and discrimination, and overall inadequate care. Pre-pandemic, 1 in 3 American adults of working age with disabilities did not have a primary provider. 1 in 3 had unmet health care needs due to cost, and 1 in 4 did not even have a routine checkup during the past year. So today's hearing really marks an overdue conversation. So many have described to me an overwhelming feeling of isolation and marginalization. Some often feel just completely invisible. Like so many other areas, COVID 19 may have compounded feelings, but they were there before the pandemic. Systemic problems in our healthcare system and social biases have led to millions feeling left out and forgotten. Today, we will work to correct these wrongs and take a more intentional approach moving forward to ensure inclusion of all individuals and equitable access to our healthcare systems. I want to thank all of our witnesses for the insights that they will share today. And I'm particularly pleased today to welcome Vern Buchanan as our new ranking member. As one part of our many years of serving together here on the Ways and Means Committee, I previously served as ranking member when he chaired the Human Resources Subcommittee, now known as Worker and Family Support Subcommittee. I'm pleased to continue our productive work together and know he is committed to finding reasonable bipartisan solutions to the many healthcare access, quality, and affordability challenges we face. Welcome, Ranking Member Buchanan, and welcoming also your opening statement.
Well, thank you, Mr. Chairman, and I agree. We've had a good working relationship in the past, and we want to continue to build on that in the future. So first, I'd like to say I'm excited to be serving as the new Republican leader in Ways and Means Health Subcommittee. I look forward to working with you and the rest of the subcommittee members more in this new role. I hope we can continue the important discussions like the one today to find meaningful bipartisan solutions to lower healthcare costs and expand choice and access for patients across the country. With the onset of COVID-19 pandemic, challenges faced by individuals with disability and chronic conditions came into a sharper focus. It is well documented that people with disabilities and chronic disease have a high risk of serious complication related to COVID-19, including a higher likelihood of death. The National Council on Disability found that these individuals were also at a higher risk of receiving less adequate COVID-19, if you can believe that, treatment in hospitals and other settings. And as we discussed yesterday in the full committee, in terms of that hearing, while the pandemic continues to affect mental health crisis across the country, in many cases, people with mental health disability is a big factor, and in many ways getting worse. In early 2020, when the pandemic first hit, thanks to swift action by Congress and Trump administration, numerous waivers and flexibilities were implemented so that patients could connect with their providers without the fear of exposing themselves to COVID-19. During the first month of the public health emergency, telehealth utilization scored to an unprecedented level as the national weekly average of Medicare beneficiaries utilizing telehealth services jumped from approximately 13,000 people per week to 1.7 million. While these numbers have since decreased, the number of patients using telehealth services is still well above pre-pandemic levels. The past 2 years have demonstrated how telehealth can be a tremendous, powerful tool, particularly to patients with disabilities and chronic conditions, and reduce the challenge and barriers faced by these individuals. It is evident that access to telehealth services needs to remain intact after the pandemic ends. People with disabilities and chronic conditions have greater benefits from video conference and audio-only visits as telehealth alleviates many hurdles that comes with getting to an in-person appointment. Numerous reports have found how telehealth has improved access to care, and patients deserve to keep access to many of these in terms of advancement. Telehealth has reduced or eliminated longstanding barriers for patients who live in remote areas, and many, in my case, where I have one of the oldest districts, has really made a huge difference for our seniors. Since these individuals tend to report improved access to their specialists and better clinical outcomes, given the process we've made in the past 2 years on telehealth, we should move forward, not backwards, on Congress, and Congress cannot let these essential benefits expire. With COVID-19 quickly becoming an endemic, rather than a pandemic, we need to ensure that expanding access to care does not disappear. In fact, just in the last week, the Florida Senate passed a bill to only telehealth as an acceptable care delivery method. Congress should follow the Florida lead by preserving telehealth flexibility. Mr. Chairman, I would like to submit this letter for the record of the National Council of Disability to the Congressional Budget Office. It's marked April 21st, which states that countries rely on these metrics to set drug prices, have restricted or denied patients with disability access to effective drug use to treat chronic conditions and breakthrough medications.
Thank you. Without objections, made part of our record.
And again, I'd just like to also say, in terms of wrapping up, I look forward to working with you. I think we can this is a space, there's going to be a lot of opportunities in the next year. I'm very excited to be a part of this. Thank you, and I yield back, Mr. Chairman.
Well, thank you so much for your insights, and I certainly share your interest in doing that and know we can work together well. Without objection, all of the other members' opening statements will be made a part of our record. And as we begin our panel's oral testimony, I note the widespread interest that our hearing has already garnered. I appreciate the groups and individuals who have submitted important written comments for our hearing. Without objection, statements from the following organizations will be included as part of our record and shared with all the members of the committee. A report from the Texas Democrats with Disabilities Caucus, compiled by President Jody Gidsett. A report from the Coalition of Texans with Disabilities, compiled by Executive Director Dennis Burrell. Statements from the Alzheimer's Association, the American Medical Association, the Healthcare Leadership Council, the Center for Fiscal Equity, the National Coalition for Assistive and Rehab Technology, and William Hanlon of Minneapolis. We appreciate all of these. Now let me recognize and welcome our distinguished witnesses to discuss access and inequities in healthcare for people with disabilities and chronic conditions. Thanks to each of you for appearing today to discuss this issue. Ms. Liza Fisher from Houston, a member of the Long COVID Alliance, who will share her personal story. Dr. Monica Verduzco Gutierrez, a medical doctor who is a professor and chair of the Department of Physical Medicine and Rehabilitation at the University of Texas Health Science Center in San Antonio. Bethany Lilly, an attorney who is the Senior Director of Income Policy at the ARC. Dr. Rupa Valdez will come next. She's an Associate Professor of Engineering Systems and Public Health at the University of Virginia. And Dr. Ray Dorsey, who's a Professor of Neurology at the University of Rochester Medical Center. Each of your statements will be made a part of the record in its entirety. I'd ask you to summarize your testimony in 5 minutes or less. To help you with that time, please keep an eye on the clock that you should have pinned there to your screen. If you do go over your time, I may just tap lightly to try to ask you to conclude your remarks. And also, as we begin the hearing, I want to acknowledge the work of my staff in meeting with you and in helping us develop today's hearing. So, Ms. Fisher, would you please begin?
Hello. Hi, my name is Liza Fisher from Houston, Texas, and I'd like to thank you to the committee for having me here today. I'd like to tell you my story as it represents the experiences of many people from the chronic illness community, the post-COVID community, and the disabled community. In June 2020, I became sick with what I thought was a sinus infection until one day I woke up feeling like a truck hit me. I was having respiratory symptoms, headache, fatigue, and sore throat. I had been struggling to breathe, but things turned really bad when an invisible elephant started sitting on my chest. A few days later, I ended up in an emergency room with my feet turning blue, gasping for breath with an uncontrollably high heart rate. My chest x-ray came back with a spot of pneumonia, and a few days later, my PCR test came back positive. I was told to go home and try to recover. You're young and healthy. It should be a rough 2 weeks, but you'll get better. And I had thought the same. However, the next week I was back in the emergency room and I felt like I was dying. I ended up at a hospital that was treating COVID patients, and I was seen in a tented facility in the hospital parking lot. I was then sent to an isolated COVID wing where I waited for hours and was then told again to go home and drink Gatorade. I explained my situation and continued to beg for treatment. However, I was told there was a 2-day wait for hospital beds and it just wasn't going to happen. Try to go home and tough it out. After being turned away from the hospital, I found a practitioner who would see me virtually for the next few weeks, and as I continued to worsen and develop neurological symptoms, again, my provider told me to go to the emergency room. Around 5 weeks later, after my initial infection, they admitted me to a COVID ICU. I spent a week in the hospital and then was released to a rehab hospital. Within 10 days at the rehab hospital, I started to develop severe tremors, neuropathy, and lost my ability to walk. While I was in the rehab hospital, everyone had told me that I needed to start applying for a disability. I struggled with that concept because I just didn't identify with it. But later in 2020, I started the process for applying, and in June 2021, I was approved. My doctor was so excited because we would finally be able to get the medications that I needed to without having to struggle and fight with insurance in order to receive them. However, we were both surprised when I found out that I had to wait the additional 24 months before receiving the healthcare portion, being Medicare, that came with it. I talked to a social worker and found out that the waiting period wasn't 24 months from when you are considered disabled, but it's 24 months from when you are approved for disability. So that added an additional 5 months. For me, this gap in coverage caused my family to dip into our retirement savings. For others, this gap in coverage can be even more catastrophic. At this point, I'd like to note that I had been unable to work since June 2020, and I was paying for COBRA insurance. I survived with the help of my friends, family, and coworkers that had started a GoFundMe while I was in the hospital. Too sick to work, I had started to look at different insurance options. Although none of those options allowed me to see all of my specialists and cover all of my medications that I was on, some of those being important, like my heart medication, my asthma medications. I thought, wow, this system is really meant for you to fail and never get better. The situation has been catastrophic to my life. I'm now not only using mobility devices, including being in a wheelchair still and having to relearn how to walk, but my family has also been affected. My mother had to move in with me and she no longer works. Overall, my story is a little bit of a roller coaster, but these experiences reflect what many people face every single day. So although you only hear my voice right now, it is the voice of many. The Solve Long COVID initiative estimates that before Omicron, between 15 to 30 million Americans have experienced long COVID. And the COVID-19 Long Hauler Advocacy Project recently wrote to President Biden that the current estimated total income lost by COVID long haulers is approximately $88.8 billion. We're about to see a mass disabling event from post-viral illnesses, something that has been ignored for far too long. So in summary, I just really urge you to consider removing the waiting period for Medicare because it would make such a tremendous impact on so many lives. And please consider the huge number of long COVID and post-viral illness patients that need support and equal access to coverage and care. Thank you.
And thank you so much for telling us your personal story, and I wish you well. Dr. Verduzco Gutierrez.
Thank you, Chairman Doggett and honorable members of the Health Subcommittee. Thank you for inviting me to speak today to the real Congress, as my 12-year-old son was really questioning me about this. My name is Monica Verduzco Gutierrez, MD. I'm professor and distinguished chair of rehabilitation medicine at the University of Texas Health Science Center in San Antonio. I'm approaching my testimony from the perspective of a physical medicine and rehabilitation physician who treats people with disabilities and chronic conditions. Before the pandemic, my patients had brain injuries or strokes. And now I care for an expanding new patient population of persons with long COVID, and I'll be asking you to ensure that they get access to the care they need. In August 2020, before we had even names like PASC or long COVID, persons with COVID-19 began to show up with fatigue. that they said was 100 times worse than their cancer-related fatigue, or brain fog that was like chemo brain. They had dizziness that was so bad it kept them in bed, but they were thankful for the telemedicine visits, and shortness of breath that kept them from work or playing with their kids outside. It was a few when I started these clinics, and now estimates say it could be upwards of 14 to 19 million people in the United States. Today, I'm going to share with you a tale of two clinics. I set up a clinic at UT Health in an academic medical center with many patients who have insurance, FMLA, short-term disability benefits, access to specialists, and health literacy and broadband. My other clinic at the University Health System, which is the county safety net hospital, had longer waits, fewer resources, and patients who couldn't even get in person or connect to telemedicine. One of these patients had survived over a month in the ICU and months in the hospitalization from COVID. And she finally got to see me in the clinic. And that day that she saw me, her legs were so weak she was unable to walk. And it was also the last day of her employer-based health insurance coverage. She was saved by all these technologies at the front line, only to be denied access to any therapy to help get her life or her job back. And patients are unable to afford the costs of long COVID treatment out of pocket, especially the wide range of services that these patients need. With well over 50 symptoms and visits that take me over an hour, long COVID is best addressed with a multidisciplinary approach, and these clinics must be supported. I've also been seeing insurers to start denying coverage of services and treatments for patients with long COVID. They say there's a lack of evidence-based practices. This is a new disease, and it takes years to develop these practices. I've been told also a patient with long COVID can't do a neurorehabilitation program because they didn't have a traditional traumatic brain injury. But research shows long COVID overlaps with the same symptoms that patients with brain injury have, such as memory, cognition, physical deficits, insomnia, depression, anxiety, and suicidality. So why am I telling you this? I see patients who are both affluent and those who are in a safety net system, who are often minorities from marginalized groups, and many have pre-existing disabilities. This group, they are most vulnerable with most barriers to access to care. They're at increased risk of exposures, disability, and death. We're seeing enormous resource strains. And for me to care for more long COVID patients, I actually have to see fewer brain injury and stroke patients and vice versa. Everyone suffers. Wait lists are upwards of 6 months, and action needs to be taken to support the healthcare workforce for these clinics, along with research and treatments. I'm thankful that you heard from Ms. Fisher. I want you to know that for many, long COVID is a disability. It disrupts lives and goals and futures. It is the worst of times. I know that the members of this committee understand that the long wait to get disability benefits is a problem. Patients who I've cared for during my career who have to wait for 2 years to get Medicare are not getting any better. These patients are getting worse. Ones with severe brain injury, their muscles shorten and painfully twist in, and families cannot care for them at home. Congress has the ability now to help bridge health equity gaps and support them by supporting the Stop the Wait Act. As an advocate for persons with long COVID and other post-viral chronic conditions, I can only do so much for this population as I see one person at a time, but Congress has a role in ensuring they get the services they need. My national society, the AAPM&R, has developed a past collaborative of 35 clinics, and we've called on the administration and Congress to develop a comprehensive plan. Thank you so much. I know many of you have been impacted, maybe your family and friends, and I'm happy to answer your questions.
Well, thank you so much for offering your insights and the valuable care you're providing to so many people. Ms. Lilly, would you please offer your testimony?
Of course. Thank you, Chairman Doggett and Ranking Member Buchanan and members of the subcommittee for the opportunity to testify today. My name, as Chairman Doggett said, is Bethany Lilly, and I am the Senior Director of Income Policy at the ARC of the United States. I am here today representing people with intellectual and developmental disabilities, their families and friends, and the essential frontline disability service providers who support them. As a person with a disability, I want to acknowledge exactly how devastating the past 2 years of the pandemic have been to my community. Millions of people with disabilities and our loved ones have either lost their lives or faced 2 years of isolation and lockdown to protect ourselves. The frontline healthcare workers serving people with disabilities have faced those same risks, and we have lost many, including Angie Reeves of Virginia. We mourn all those we have lost. My written testimony goes into detail about the common challenges and barriers that people with disabilities have accessing healthcare, the impact the pandemic has had on all of this, and how we can move forward to build a more equitable system. But to provide some highlights, all people with disabilities need health insurance, as we have just heard very clearly. But we currently have a haphazard system of multiple private and public options that leaves many gaps: Medicaid, Medicare, the VA, the Indian Health Service, employer-sponsored coverage, and the Affordable Care Act, to name a few. These gaps in access are concerning for everyone, but even more so for people with disabilities who often rely on healthcare to maintain their existing level of functioning or their ability to live in the community. And the 2-year waiting period for access to Medicare for SSDI beneficiaries leaves people with some of the greatest needs without affordable healthcare. This is why we support Chairman Doggett's Stop the Wait Act. We also support efforts to close the Medicaid expansion coverage gap and to improve the affordability of ACA subsidies to make sure everyone can access healthcare. In addition, particular services are crucially important for people with disabilities. Many people with disabilities rely on home and community-based services called HCBS to not only keep themselves healthy, but to allow them to fully participate in their communities. Approximately 23% of all COVID deaths occurred in congregate settings that are the alternatives to HCBS. So it's no surprise that both people with disabilities and older adults prefer community settings and services. This is why over 800,000 people across the United States are on waiting lists for HCBS. We desperately need comprehensive investment in HCBS so that people with disabilities can access the services they need. I know many members of this committee have co-sponsored the Better Care, Better Jobs Act, and I thank you for supporting that investment in people with disabilities. But access to HCBS isn't enough either. People with disabilities also need other comprehensive services, as Liza mentioned earlier. We need an out-of-pocket cap on Medicare Part D, so beneficiaries aren't on the hook for thousands of dollars in out-of-pocket costs for life-saving medication. Medicare needs to cover all basic healthcare services, including comprehensive dental, vision, and hearing benefits in Part B, so that people with disabilities and older adults have access to these services. And the healthcare system as a whole must acknowledge and treat people with disabilities as real people. As Ranking Member Buchanan mentioned earlier, over the past 2 years, my network has repeatedly had to bring lawsuits or file complaints with HHS about crisis standards of care and hospital visitor policies discriminating against people with disabilities and their families. Unfortunately, this kind of discrimination is not new. We have seen it in access to organ transplants and other areas for years. Research makes it very clear that many in the medical profession do not see people with disabilities having the same quality of life as people without disabilities, and the structures and biases of the healthcare system reflect this. This deep-seated bias against people with disabilities is all the more concerning, knowing that COVID is a mass disabling event. I know members of this committee have done work to address the needs of people experiencing long COVID and other post-viral conditions like Liza, and I hope we see those investments come to fruition soon. It is also crucial that we have data on people with disabilities, both experiencing COVID and otherwise, that is collected with full stratification of reporting by key demographic groups. Finally, I want to highlight 2 things that the committee is focused on legislatively that we are supportive of. First, I hope that the investment the committee has proposed in medical students with disabilities are enacted soon. This is an effective way to begin to reverse bias and push back on misconceptions about people with disabilities within the healthcare system. And second, I hope we see action on telehealth soon. Recent Data for Progress polling shows that 80% of all likely voters want telehealth flexibilities extended, and we do too. We just need to ensure that these options are available and accessible to all people with disabilities. Similar things need to be done to ensure that they work for people in rural areas as well. And that's the important point about ensuring that people with disabilities are included. If policy works for us, it will work for everyone. Working on solutions is how people with disabilities and organizations representing people with disabilities have responded to the pandemic. That's why I'm here today, and I look forward to answering the committee's questions.
Well, thank you so much for valuable insights on a wide range of important issues. Thank you. Dr. Valdez, will you please proceed?
Yes, of course. Chair Doggett, Ranking Member Buchanan, distinguished members, thank you for this opportunity to testify. My name is Rupa Valdez, and I am an Associate Professor of Public Health and Systems Engineering at the University of Virginia. I also serve on the Board of Directors for the American Association of People with Disabilities. However, I am testifying today in my individual capacity. I have dedicated my career to understanding how people manage chronic health conditions and to designing systems to support them in doing so. In particular, I have focused on rural communities, communities of color, and the disability community. Our discussion about disability must be viewed as intrinsically linked to discussions about veterans, rural communities, older adults, and communities of color, since disability is overrepresented in each of these communities. I speak to you today as a disabled person of color who both experiences and seeks to address the many structural and attitudinal barriers to health equity faced by the disability community. These barriers are numerous and complex, spanning factors related to broader social inequities, such as education, employment, socioeconomic status, and histories of institutionalization, as well as factors more specifically related to healthcare delivery systems. Although all must be addressed for equitable care, I will focus on 6 barriers at the level of healthcare delivery systems that should be considered in any upcoming legislation. First, the disability community is often excluded from efforts to improve health equity, despite experiencing significant disparities. 1 in 3 people with disabilities does not have a primary health care provider. Disabled people also experience disparities in health outcomes, such as disproportionately high rates of chronic health conditions and disproportionately high mortality rates during the pandemic. For more efforts to focus on addressing these disparities, the disability community must be formally recognized as a health disparity population. Second, although existing legislation requires people with disabilities to have both full and equal access to healthcare services, in practice, over 75% of people with disabilities experience barriers that impede their access to these services. We must enforce and expand existing legislation and regulation to be fully responsive to the needs of the disability community. Third, without appropriate data, it is nearly impossible to systematically detect and address health disparities experienced by the disability community. Thus, we need clear and comprehensive requirements for data collection about disability status across health systems. Fourth, health professionals have limited understanding of the needs of people with disabilities. A recent study found that only 40.7% of physicians report feeling very confident in their ability to provide the same quality of care to their disabled patients. The education of health professionals must therefore explicitly encompass the needs and experiences of the disability community. Fifth, disabled people are severely underrepresented in health professions. While 25% of Americans live with a disability, this number drops to 3.1% for practicing physicians. Representation is essential, even life-saving, especially when policies must be crafted quickly and before federal guidance is available, as in the case of crisis standards of care drafted during the pandemic. Revision of discriminatory policies related to technical standards to enroll in training programs and licensure revocation would improve representation. Finally, for some people with disabilities, telehealth has meaningfully improved access to and quality of care, yet many barriers still remain. These include disproportionately low access to the broadband and hardware needed for telehealth, the inaccessible design of many telehealth platforms, and the failure of many health systems to implement telehealth in ways that meet the needs of the disability community. Moreover, disabled people may experience negative unintended consequences of the movement to telehealth if expansion proceeds without appropriate guardrails. If telehealth becomes viewed as a measure of cost containment, healthcare providers may discourage in-person visits. This would likely have disproportionately adverse consequences for disabled individuals, for whom in-person visits may be more clinically appropriate and accessible. Thus, telehealth solutions must be designed, implemented, and evaluated in ways that account for the specific needs of disabled people. To end on a personal note, the chronic conditions with which I live have impacted everything from what I eat, to how much I am able to use my arms and legs, to the length of time I can look at printed words or screens. However, in the context of my work environment, with the appropriate attitudes and structures around me, these disabilities have not limited my ability to thrive. For example, as I wrote my testimony, I spoke words aloud to an assistant, and she both typed them and read them aloud to me for editing. Without the system molding to fit my accessibility-related needs, such work would be impossible for me. What is essential then is for systems to be designed to fit the needs of all people. Addressing these 6 barriers would be meaningful steps towards creating a healthcare system which does just that. Thank you, and I look forward to your questions.
And thank you for sharing your personal experience as well as your very important policy recommendations. Dr. Dorsey. Dr. Dorsey, can you unmute there and please begin?
Yes, thank you very much, Chairman Doggett. In the fall of 1970, Peter Smith was a 24-year-old Green Beret serving in Vietnam. He and his fellow soldiers ran special operations near the Laos and Cambodian borders. They came under fire from the North Vietnamese and were routinely exposed to Agent Orange. After the war, Mr. Smith worked in the corporate sector before becoming a math teacher. Before he retired, he lost his sense of smell and developed a tremor in his left hand. He was diagnosed with Parkinson's. He is not alone. Late General Colin Powell and thousands of veterans who were exposed to Agent Orange have developed the disease. Yet despite the diagnosis and his service, Mr. Smith could not receive the care that he needed. He traveled hours to the closest VA facility in Western New York where he lived. There he saw a physician assistant who knew little about Parkinson's. So 5 years ago, Mr. Smith began seeing me, a Parkinson's specialist at the University of Rochester, via telemedicine. He started a new medication and continued doing 200 push-ups daily. Today, his Parkinson's continues to progress. He gets frequent leg cramps and has lost over 25 pounds. Nonetheless, he remains active and now does modified push-ups. Mr. Smith is not the only person who's benefited from telemedicine. About 4 years ago, I saw a brother and a sister with a very rare genetic form of Parkinson's disease. The siblings, both in their 30s, were lying in separate beds. They could not speak, feed, dress, or bathe themselves. They, like 4 million Americans, were homebound. Their parents, both immigrants, cared for their adult children in their small home just miles away from John F. Kennedy Airport in Queens, New York. In 2013, the state of Delaware did not have a single Parkinson's specialist, not one. So nurse practitioners at the University of Delaware created a telemedicine clinic. Now patients and their caregivers don't have to drive hours to see a specialist. They can receive expert care in their own community. Today, over 40% of Medicare beneficiaries with Parkinson's disease do not see a neurologist soon after diagnosis. Those who don't are more likely to fracture their hip, be placed in a skilled nursing facility, and to die. Rural residents, seniors who are Black, women, and older individuals are all less likely to receive care. Telemedicine can help bridge these gaps. Yet before the COVID-19 pandemic, Medicare spent less than 0.1% of its budget on telemedicine. But thanks to former CMS Administrator Seema Verma, Medicare temporarily expanded its coverage of telemedicine in March 2020. In 4 weeks, use of telemedicine increased 100-fold. In 2020, the number of Medicare telemedicine visits topped 50 million. Parkinson's is the world's fastest growing brain disease. It affects all of us, including senators, including the late Johnny Isakson, and representatives like former Congressman Jose Serrano. 1.2 million Americans, including over 100,000 veterans, have the disease. Today, another 200 will be diagnosed with it, and 100 more will die from it. Yet much of this is preventable. Pesticides, industrial chemicals, and air pollution are fueling Parkinson's rise. Paraquat is the most toxic herbicide ever created. It kills the weeds that Roundup can't, and it increases the risk of Parkinson's by 150%. Over 30 countries, including China, have banned this neurotoxin. The US needs to do the same. Until we summon the will to prevent Parkinson's, we can at least care for all affected by it. Telemedicine is far from a panacea, but we've just completed a natural experiment assessing its value. Clinicians accept telemedicine, patients love it, and with its adoption, Medicare spending went down, not up. Suffering was alleviated, infections were prevented, and lives were saved. It's now time for Medicare to permanently cover telemedicine, regardless of geography. 2, from a broad range of clinicians. 3, for patients in their home. And 4, from physicians in any state. Let's not return to a time when veterans, immigrants, and rural residents are denied care that they need and that they paid for, simply because of distance, disability, or the distribution of doctors. Medicare's intent was to guarantee access to healthcare for any senior anywhere. Chairman Doggett, Congressman Buchanan, Members of the Health Subcommittee, it is time to fulfill that vision.
Thank you so much, Dr. Dorsey. I know Representative Buchanan and I, who are together, along with Representative Kelly and Representative Thompson and other members of the subcommittee on our bipartisan telemedicine bill, appreciate your comments particularly and hope that we will see action in our committee to move forward on this just as soon as possible. So at this time, having heard from all of our witnesses, without objection, each member of the committee, followed by other members of the broader Ways and Means Committee, will be recognized for 5 minutes to question our witnesses. We will not observe the Gibbons rule in this remote setting and will instead go in order of seniority, switching between majority and minority members. Members are reminded to unmute themselves when you're recognized for your 5 minutes. And I will begin by recognizing myself. I think first let me speak to Dr. Verdisco Gutierrez. You provided some powerful testimony concerning the coverage barriers that your patients face. I was particularly struck by your assessment of our response to the pandemic thus far and the guarantee of free vaccines and coverage for treating COVID, but not the same for long-term symptoms. What do you see as the most important reforms that we need to our health system to ensure that long COVID patients receive the care that they so desperately need?
Thank you, Chairman. I feel that, all patients and all persons, regardless of their circumstances, need to have access to high quality health care. As I discussed earlier, patients can get vaccines, patients can get hospitalization care when they need it, and they are not getting access to long COVID care. So part of the response may be supporting these clinics with long COVID, also ensuring that if they do become disabled, that they stop the wait and are able to get Medicare, so then they can get these multidisciplinary services that they need.
Thank you. Ms. Lilly, what reforms do you believe are needed to expand coverage and how will they reduce inequities for people with disabilities?
I think your Stop the Wait Act would be an excellent start, Chairman. I think that we have a lot of gaps in coverage, and when folks are waiting for comprehensive coverage, as has been discussed by Liza and Dr. Gutierrez, that can really result in functional declines. It can sometimes result in death, as you pointed out in your opening statement about those stuck in the waiting period. So I think making sure that everybody has access to coverage and then making sure that that coverage is comprehensive is one of the most important things we can do here. I know that you've also led bills on making sure that coverage is comprehensive and closing the Medicaid coverage gap and things related to that, I think would be really important steps in the right direction. I'll also add improvements to the advanced premium tax credits. Those are another one of those kind of cliffs that we have coming up, like with telehealth, where we have past improvements, but those improvements need to be extended. And so I'd really like to see Congress pay attention to that and take some action to make sure that happens as well.
Thanks. And I think you also made reference to the importance of dental, hearing, and vision care for people with disabilities. I have legislation on that as well to assure Medicare coverage for those areas. Can you comment on that?
I'll comment that 2/3 of people with disabilities on Medicare haven't been to a dentist in the past year. That's even worse than for all Medicare beneficiaries. That rate's 50%. So this is one of those areas where the disproportionate impact of not having comprehensive coverage really impacts people with disabilities. And on a very practical level, that means for people with disabilities, they're not going to be able to deal with some of those things that come along with complications in their teeth. If they get an infection, if they can't get you have a tooth break and then it starts to develop an abscess, that's something that we need to start treating as early as possible. I'm sure Dr. Gutierrez would agree with me on that point. The earlier we can access these things, the more preventative care we can provide, the better. it still kind of shocks me that we have a healthcare program like Medicare that's designed to serve people with disabilities and older adults, and it doesn't cover hearing aids and it doesn't cover routine eye care and glasses. Those are just basic healthcare services that we really need to have access to. So I really appreciate and support your efforts to expand Medicare to cover those very basic healthcare services. I think that it's important that we cover them through Part B, because that would ensure that they're fully integrated into the Medicare program, and it would allow all the existing low-income protections we have. I think that was a really important point made earlier, that for low-income beneficiaries, sometimes that cost sharing can get really out of hand. So making sure that those low-income protections are there is really crucial. And I'd also add, I mean, yes, this is an expansion of services, but I think we can expect that, we can phase those types of additional benefits into the program. We can make sure that increases to the premiums remain low, and so folks aren't immediately noticing that. I think this is a really responsible thing to do, to give people access to these basic services and to build out the preventative healthcare system.
And Dr. Valdez, especially after the very powerful testimony of Dr. Dorsey about telemedicine, I wonder if you might comment briefly on the impact that you believe our Telehealth Extension Act can have on people with disabilities and efforts to get greater health equity.
Yes, absolutely. So I would highlight two things that were mentioned by other witnesses as well today. So the first is the idea that you can engage in healthcare from your own home and your own community. And this is so important for many people with disabilities because, one, their home and community spaces may be more accessible for them than any clinical spaces may be, or any designated healthcare sites. And as we also talked about earlier, they may also, especially in the case of the pandemic, be safer for them as well. It also allows people with disabilities to avoid other challenges they may face to accessing healthcare. So one thing that comes to mind is transportation. Many people with disabilities might rely on public transportation or rely on others such as family and friends to get to a healthcare appointment. And so telehealth also removes those types of barriers to access. On another dimension that I think is also worth mentioning is, of course, the expansion of approved providers and services. And so here we have seen, of course, an improved access to specialists for many in the disability community, as well as a reduction of wait times. So certainly extending those provisions will be of benefit to the disability community.
Thank you so much. And Ms. Fisher, my time is about expired, but I want to thank you again for your powerful testimony and commend your courage and strength in the face of this overwhelming ordeal with which you have been coping. Your testimony has helped us a lot. I would now yield to Mr. Buchanan to ask his questions.
Thank you, Mr. Chairman. Dr. Dorsey, I want to thank you for your background, all the work that you've worked in this space in terms of Parkinson's. I know it's personally to me and my family, because I have a brother-in-law that served in Vietnam that get with Agent Orange, and he's dealing with Parkinson's the last 4 or 5 years with different drugs and different things. So when, if you're not impacted or it's put right in front of you, sometimes we're not as sensitive to a lot of these things. But I want to thank you for all the things you're trying to do to improve care, new treatments, and I know that's a lot of your focus. But going back to telehealth, and I do think personally myself, it's the future, but how much has that grown in terms of your experience as a result of COVID? And then as you look forward, how big of a growth area is this? Because it seems like, we'll talk about cost in a minute, but it seems like an area that can be a lot more efficient than the way we're doing things right now. What's your thoughts?
Thank you very much, Congressman Buchanan. I'm sorry to hear about your brother-in-law. If I can be of service, please let me know. So I started seeing patients with Parkinson's disease remotely via telemedicine in 2007. We started seeing nursing home residents in upstate New York who had no access to neurological care. And people looked at me quite oddly when we started doing this in 2007. And really, telemedicine was a niche industry until the COVID pandemic, until Medicare decided to cover it. As mentioned earlier, less than 1 out of every $1,000 Medicare spent went to telemedicine before the pandemic. I think we're only scratching the surface of what is possible. Today, we think about telemedicine being an encounter between a physician or a clinician in a patient, we can start thinking about one clinician caring for many patients. One of my patients with Parkinson's in upstate New York participates in online physical therapy with a physical therapist based in Boston, and does so with tens of his fellow colleagues who have Parkinson's disease. We can also start thinking about many clinicians seeing one patient. So as many of the witnesses have testified, people with disabilities have a myriad of needs, and sometimes those needs can't be met by a single clinician, and they require care and coordination from multiple clinicians who could actually see the patient at the same time or in many different ways. We're only scratching the surface of what's possible. And if you think more broadly, it's kind of odd that we ask generally sick patients to see generally healthy clinicians on our terms. We should be seeing sick patients on theirs.
And let me ask you, Doctor, as it relates to, you talked about cost. I mean, we're all sensitive about skyrocketing cost in healthcare, but your thought was it's actually reduced the cost. Has that been your experience? Because it seems like it makes sense, but there's obviously a lot of concern about cost. And what's been your experience?
Not just my experience, those are the facts. So we know for Parkinson's that people with Parkinson's who see a specialist are less likely to fracture their hip, less likely to have hospitalizations, and have lower healthcare expenditures than those who don't. We know from the experiment, the CBO should look at the data. We did the experiment, we vastly expanded the coverage of telemedicine, and expenditures on physician health services went down $14 billion. When do you hear that being the case? More broadly, why do we incent institution-based expensive care by providing institutions facility fees and disincent patient-centered inexpensive care? We should provide care to patients based on their needs and their preferences, and stop subsidizing institutional care and start incenting patient-centered care.
The other thought I had, what impact, if any, the idea around telehealth, the uncertainty of what role the government's going to play or not, do you sense? I mean, is it a big thing for you in terms of the uncertainty, or different industries, specialties, I should say, maybe with doctors in terms of telehealth?
It's a big uncertainty for those who receive care via telemedicine, whether you're disabled, whether you're a rural resident, whether you're a veteran, whether you're relatively healthy. Almost everyone has benefited from telemedicine in the setting of the pandemic. The winners of telemedicine are patients. It's really not clinicians. They benefit from the care, the convenience, the comfort, the confidentiality, and the risk-free, being free from COVID.
I can tell you, I'm in an area that we're probably one of the most senior members of the group in terms of our area, in terms of a lot of seniors, and that's a big concern, is the convenience of telehealth. But thank you, and I yield back, Mr. Chairman.
You can proceed, Mr. Higgins.
Oh, I'm sorry. Thank you, Mr. Chairman. Dr. Dorsey, you had indicated in your testimony that over 100,000 veterans are afflicted with Parkinson's, and yet, the information that we have is that the standard treatment for Parkinson's in terms of therapeutics is an era of drugs that were developed over 50 years ago. Why hasn't there been more progress in terms of drug development as it relates to a disease that afflicts a lot of veterans and a lot of people in the general population as well?
Thank you very much for the comment. So as you rightly point out, we had more therapeutic breakthroughs for Parkinson's last century than we have had this century. We have no highly effective treatments for Alzheimer's disease, which affects 6.2 million Americans. Why is that? I think there are a couple of factors. One, we're really poor at measuring the disease. We continue to rely on subjective measures based on input from experts to determine whether a new drug or device works. Literally today, we have people tap their thumb and index finger, and they have someone like me rate that as slightly affected, mildly affected, moderately affected, or severely affected. When we have subjective measures of disease, we're not going to get new therapeutic breakthroughs. Second, we need vastly more resources devoted to it. NIH funding on Parkinson's disease has actually decreased over the last 10 years when adjusted for inflation. At the same time, the number of Americans with the disease has increased 35%. And we need more investigation from pharmaceutical companies. I'd also point out one great lesson from COVID: it's way easier to prevent disease than it is to treat disease. And we need to start attacking the root causes of Parkinson's disease, including pesticides, industrial chemicals, and air pollution. Start attacking the root causes of Alzheimer's disease, which is largely air pollution, as well as many other conditions.
Does the messenger RNA technology which is an incredible biomedical achievement that I think, is really the story of this pandemic, does that hold potential relative to new treatments, a new generation of treatments for Parkinson's?
Yeah, so both Parkinson's and Alzheimer's are due to a misfolding of different proteins. And the thought is that certain vaccines could attack those misfolded proteins, much like vaccines developed for COVID attack the spike protein of COVID-19. So that's indeed a possibility. We've seen what an Operation Warp Speed can do for COVID-19. We need an Operation Warp Speed for Parkinson's disease.
And let's say that there was an effort that is commensurate with what has occurred over the past 24 months relative to developing. The messenger RNA technology has been there for decades. What's realistic? What would be an expectation in terms of developing new treatments using the messenger RNA technology for Parkinson's and Alzheimer's?
I can't give you a perfect answer on that because I just don't know. But you saw what happened in the setting of the COVID-19. None of us expected that we would be able to get a vaccine in less than 1 year for COVID-19. We should apply that same energy, that same will, and that same determination to see what we can do for Parkinson's.
Yeah, finally, my predecessor in Congress, Jack Quinn, has Parkinson's, as does his brother Jeff. And they are very involved in Parkinson's boxing. And they really both, testify that the results of that physical therapy, if you will, has lessened the reliance on the drug and all of the side effects that come along with it. So we have been trying through the Veterans Administration, through the Michael J. Fox Foundation, to promote and to, get insurance companies to pick up the cost associated with Parkinson's boxing. Now, I know that that's not necessarily available to everybody, but it's not as though and I just want to dispel one myth about it. It's not as though they're getting in a ring and beating each other up. As you know, it's the physical therapy that is associated with boxing and the movements that help Parkinson's patients. Could you elaborate a little bit on the efficacy of Parkinson's boxing as it relates to Parkinson's disease?
Yes, Congressman Quinn's been a great champion for Parkinson's disease. And so vigorous exercise can decrease the symptom burden associated with Parkinson's disease and even prevent the individuals from ever developing the disease in the first place.
Thank you so much.
Okay, I yield back. Thank you so much.
Thank you very much. Mr. Kelly.
Thanks, Chairman. And all our panelists, thanks so much for being with us today. Let me just relate one story because it's probably something all of us, especially if you're from a district where you have a more rural district that you deal with. And there's one of our constituents who's been, she came to us for help. And here's the problem. She has MS and she has other health conditions that go with that. So she's on disability. And she should be able to see her doctor remotely via telehealth, but doesn't have a strong family, doesn't have a support group to help her. And she's not comfortable at all with using those type of tools. Now, I've got to imagine that a lot of us are in the same type of districts. And I know myself, for a lot of the things that when it comes to watching anything on what I used to just call TV, I guess it's something very much more than that now. I have my grandchildren do it for me because I get very frustrated trying to switch between all these Hulu and Netflix and all these different things that are out there. And I'm imagining I'm just trying to watch something on TV. But if you really needed help and, get to your doctor and be able to do this, we have all this wonderful technology. But this is to any of you on there. I know the general feeling, and Chairman, you and I have talked about this before, and I think all of us on the call, the answer always comes out, well, Congress needs to do something about it. And then my question is, okay, well, thank you for that encouragement, but I can't fix something with nothing. What would you suggest? What do we need to do? Because a lot of these folks just aren't up to speed on how to use all these wonderful assets that we have out there. So the piece of legislation that Chairman Doggett was talking about, that Telehealth Extension Act, this is critical. I mean, this is really critical to get that done. And Chairman, again, thank you for the work you've been doing on this. But for all our panelists, how do we overcome that lack of comfort or confidence when we tell people, hey, here's all you have to do? And it sounds good when you're having a one-on-one conversation, but once that coach leaves the room or leaves the batter's box, is not there to help you actually get through it, what's the next step there? I know, Dr. Dorsey, you've been talking about this, and I got to appreciate you all taking time out of your lives to come and do this. But that's a huge problem. We have so many things that are available today, all the advancements that we've had, but I don't think all the people who would have need for them are comfortable trying to get engaged that way. So any ideas on that, gang?
Well, I can speak on behalf of people with intellectual and developmental disabilities who I think have a lot of the same problems that older adults and seniors have when it comes to technology might be not making quite as much sense. And one of the things that, I think Congress could think about is around making sure that there are support staff to help with these things. I mean, one of the advantages to telehealth definitely is that you aren't going to have staff there, but I really appreciated what Dr. Dorsey said earlier about people with disabilities defining the terms of the interaction. And it would be the same for seniors. If you can have someone who knows they're going to have a telehealth appointment, so you make sure that they have, maybe it's not a nurse, maybe it's somebody like a direct support professional or someone who has other capacities who can come in and help with that. And that will make telehealth more expensive, but maybe that isn't as expensive as paying for medical transportation for that individual to go into an office. Maybe it isn't as expensive as paying for a full office visit. I think we could think about support staff and how they fit into this. I mean, many people in my network live in, with support staff. They have somebody who's there to help them with their activities of daily living. Many older adults and seniors need that kind of support. That's a really important function of those folks. I've done a lot of webinars with folks, and usually it's the support staff turning on the webinar and introducing me to the people. I'd also flag, especially for low-income people, oftentimes internet access is on telephones. It's not going to be via a laptop. So we need to make sure that telehealth works on cell phones and works on a lot of different platforms so that everybody has access, especially people who might not have the resources or may have limited broadband, so they're relying more on other types of network.
The VA is also another good model. The VA has satellite clinics, so people who have disabilities can go to those clinics and be connected to clinicians from around the state or around actually the VA from around the country to receive the care, so they can be supported while they're receiving the care that they need. And the second thing is we need universal broadband access. 20% of the U.S. households don't have access to broadband. We need to treat this as a utility like we do water and electricity, provide it to all households.
Thank you very much, Mr. Kelly. Mr. Thompson, I know you and a number of our committee members have been a little late coming because of the Ukraine briefing, but you'll be pleased to know that almost every one of our witnesses and our colleagues has been talking up telehealth, a cause that you've championed for so long. You have your 5 minutes, Mr. Thompson.
Well, thank you, Mr. Chairman. I appreciate that. And I appreciate the mentions by the witnesses of telehealth. I reviewed the witnesses' testimonies, although I was in the briefing on Ukraine, but I read the testimonies last night. And I tell you, I was particularly moved, Dr. Dorsey, by your testimony. I'm a combat wounded Vietnam veteran, and it was heartening to see the good that you were able to do using telehealth with a veteran colleague. And as Chairman Doggett mentioned, I've been working on expanding telemedicine, not just to my time in Congress, but back to my days in the state Senate. And I've got a favorite story that really kind of wraps up how important it is. I represented a young child who needed emergency surgery in the Ukiah Valley in Mendocino County on the coast of California. And if he didn't get the surgery right away, he was going to die. They did not have enough time to ambulance him to a hospital a couple of hours away where they had surgeons experienced to do that. And they couldn't airlift him because of inclement weather. But there was a doctor at the Ukiah Hospital who had witnessed that surgery when he was in medical school. So through telemedicine, they were able to hook him up to someone, and they believe it was in the UC Davis system, that talked him through that surgery. It saved that young boy's life. He'd be dead otherwise. So I just can't emphasize how important telemedicine is. And I'd like to give the witnesses an opportunity to talk about how important it is for patients with disabilities. And we could start with you, Dr. Dorsey, and then maybe go to Dr. Lilly.
Congressman Thompson, thank you very much, and thank you very much for your service. Most people in the United States receive too little care, not too much. And they do that because they live in rural areas like Mendocino. They do that because they have disabilities. They do that because of financial reasons. They do it because they're socially not well connected. And they do it because they're not physically doing well. Telemedicine has a chance to bring care to patients instead of patients to care, and address many of these shortcomings in the current model. I'll yield to my fellow colleagues and witnesses.
Dr. Lilly?
I think I'll simply echo what I think Dr. Dorsey said and what I know some of my co-panelists, especially Dr. Valdez, have to say on this issue. It is incredibly important, but we also need to make sure that it is accessible. And I just brought up a good example, which is, people with intellectual and developmental disabilities like Down syndrome and autism might need a little bit of extra help to be able to access telehealth services, to know which app to open, to do those steps. We can certainly build that into the system. We can make sure that the support staff that serve people with disabilities know how to use telehealth and how to complement it. And I think it's incredibly important. Something that was mentioned earlier during the opening statements was that this is a much safer option for a lot of people with disabilities, especially right now because of the pandemic. And that also is something that's really important for me right now.
Thank you for saying that. It was my bill that extended it, that put it in place for treatment for Medicare recipients during the pandemic. So I'd like to see that run out long as well. And I have some of the same concerns. I want to make sure that there aren't barriers to access to telemedicine. We already know that's a problem with existing models, and if we don't structure it in a way that precludes that from happening, we're going to create a situation where some people have access and others don't. And it's not just a rural area, a rural issue anymore. It used to be, telehealth used to be all about underserved areas, specifically rural areas, but now we're learning that it's just a good model to help facilitate delivery of healthcare in urban areas and to people in areas where there's plenty of access. So we just need to make sure we do everything we can to make it accessible to anyone. And if any of the witnesses would like to elaborate on that, I'd be interested in here, or otherwise I'll yield back.
I do just want to say that for persons who have long COVID, telemedicine is so important because it's just so fatiguing for them. Even going to a doctor visit will knock them out for weeks or exacerbate their symptoms. So thank you for making it accessible for that patient population.
And thank you. I believe Mr. Thompson's time has expired, but I know there'll be an opportunity to discuss this more with other members of the committee. Mr. Jason Smith, you're next.
Thank you, Mr. Chairman. Much of this hearing today has focused on the challenges in assessing care faced by those suffering from disabilities and chronic conditions. For many people, that likely means that they lack insurance coverage. But for rural Southeast Missouri and frankly, most rural communities across this country, the issue isn't access to insurance, it's access to care. For my folks back home, the The doctor may be in, but the specialized care they need could be hundreds of miles away. Worse, the number of rural providers is shrinking. Missouri alone has the 8th most rural hospital closures of any state since 2005, and 42% are on the cusp of shutting their doors forever. Imagine how much more difficult accessing care must be for someone who's disabled or ill when there's a shortage of providers in rural and underserved areas. The situation is dire, and it's growing worse every day. And for Southeast Missouri, telehealth has become essential for care. And I want to thank our witnesses today for highlighting the value that expanded telehealth has presented for patients struggling with acute and chronic conditions nationwide. But sadly, the future of telehealth as a mainstream treatment option remains uncertain. After April 16th, the public health emergency for COVID-19 is set to expire. And in many ways, that's a good thing. Moving past the COVID-19 pandemic is long overdue. And I hope that President Biden and Democrats take this opportunity to stop using a permanent pandemic narrative as an excuse to subject students to mask mandates in schools, implement unconstitutional vaccine mandates in the workplace, and control the everyday lives of the American people. But as usual, Biden's bureaucrats and Washington Democrats are setting up rural America to fail. When the public health emergency expires, telehealth as we know it will go back to pre-pandemic rules, with red tape and Washington gimmicks keeping patients away from their doctors. This includes going back to the old rules for audio-only services. As helpful as video-based telehealth is, it is often unavailable for many rural Americans. Southeast Missouri is no exception for rural America's struggle with broadband access. And while I'm on the front lines of the fight to ensure that Southern Missouri receives every dollar and resource it is due in order to have access to high-quality broadband, in the near term, we cannot pull the rug out on folks by letting the audio-only option expire. Missourians can't delay receiving care because the doctor is just too far away. Video telehealth technology will not catch up fast enough to help those I serve, which is why audio-only telehealth is so essential. I authored the Permanency for Audio-Only Telehealth Act to fill this healthcare void and ensure Southeast Missourians have access to care. My bill will benefit all rural Americans, including those with disabilities and chronic conditions. Dr. Dorsey, would you support making Medicare's coverage of audio-only telehealth permanent?
Yeah, so audio telemedicine certainly has enormous benefits for 20% of households that don't have broadband access. For many conditions like mental health conditions, audio can be done and served well. One of the largest telemedicine companies in the country uses predominantly audio-based telemedicine. Of course, as you recognize, there are limitations to audio-based telemedicine for certain conditions where visualization is important, like rashes or tremor, but certainly has an important role to play in increasing access to care.
Thank you, Dr. Dorsey. I yield back, Mr. Chairman.
Thank you, Mr. Smith. And now Ms. Sewell. Can you unmute, Ms. Sewell?
So sorry. I should have a t-shirt that says, please unmute. Chairman Doggett, thank you for holding this afternoon's hearing. It is no secret that both disabilities and chronic diseases are some of the biggest threats to our community's health and well-being. Disabilities, which impact 1 in 4 Americans or 1 in 3 adults in my state of Alabama, cause major disruptions to individuals' lives, and unfortunately, the percentage of people living with disabilities is highest in the South. Places like my home state of Alabama, which in 2019 had the 6th highest percentage of people living with disabilities. In fact, one of my constituents deals with chronic migraines all the time. Her name is Ashley Green. And Ashley Green is one of 60 million Americans who have chronic migraine attacks. Ashley, who is now 41, was diagnosed at the age of 6 with chronic migraine disease and has suffered mightily. She's actually one of the fortunate ones because she has a support group at home that makes sure that she can deal with the ongoing effects of this disease. Ashley is the face of problems of health inequities in chronic conditions. And so I am particularly focused on the inequities in our healthcare system. I was fortunate enough to serve as co-chair of the Rural and Underserved Communities Health Task Force that Chairman Neal established, and most recently co-chair of the Racial Equity Initiatives. In both cases, we sought to find solutions to address the health inequities that exist in our system. Congress must commit ourselves to reducing the cost of healthcare. That is why in Build Back Better, I was excited to see that we were seeking to stabilize the Affordable Care Act by providing more premium subsidies. I also believe that we must invest in in-home and community-based services. And I also think that the policies that we should promote should also address the structural inequities in our health system. My question is to Dr. Valdez. I was interested in your work on managing health at home and in communities, especially marginalized populations. Can you elaborate on policies that Congress can laws that we can actually pass that can help manage in-care and home care diagnosis?
Yes, I'm happy to speak to that. And I know some of the other panelists can speak to this as well. So one of the things I would certainly highlight is, and I know as one of my co-panelists also highlighted, is the importance of home and community-based services for members of the disability community. And so this is something that is, of course, desperately needed by many. And there are over 850,000 people on waiting lists, as you know, for Medicaid home and community-based services. And many people with disabilities, including the people that I work with in my own work, rely on services such as home and community-based services, or in the case of your constituent that you mentioned, family members or friends, to engage in a whole range of activities of daily living and to engage with their communities. And I speak also as a disabled person that this is true for my own life as well, where I also rely on family and friends and other support services to engage in everything from the work that I do to meal preparation and other activities of daily living. And so
can you also address your work with marginalized communities, especially communities of color, when it comes to health inequities?
Yes, absolutely. That's such an important point to bring up. And I think of this as the 2 points really to consider here. And so first, the fact that disability is overrepresented in some of our communities of color in both Black and Native and Indigenous communities. And so this conversation kind of by its very nature focuses on communities of color. And the second is that the experience of being a person of color and a person with a disability is one of compounded marginalization. And yet this is an experience of compounded marginalization that remains largely invisible in many of our efforts to address health equity. So for example, when data about any health condition, health outcome is reported, sometimes it will be stratified by disability status or by race and ethnicity. But results are rarely looked at in terms of the experience of people holding both identities. And we do know, of course, that it's a different experience for those who hold both identities simultaneously. And this, I think, really emphasizes the need to create programs and policies that attend to and target disabled people of color.
Thank you very much. Thank you, Mr. Chairman.
Thank you very much, Ms. Sewell. Ms. Chu.
Excuse me?
Oh, Dr. Winstrup, go ahead.
Thank you. I thought I was next. Anyway, I apologize. I want to thank everybody for joining us today. One of the things I talk about a lot as a physician, especially, is the difference between looking at lifespan and having a long lifespan compared to having a good long health span. And, how do we keep people healthier longer? How can we have early interventions, mitigate diseases how do we prevent, cure, or even more so prevent something from getting worse? And I want to thank Dr. Dorsey. You kind of touched on that today. We know there's economic barriers, there's access barriers for a lot of different reasons, but we're always trying to go towards things that can make people healthier longer. Representative Blumenauer and I have a bipartisan bill, the Chronic Disease Management Act, that would give health plans the tools to keep people healthier longer through allowing high deductible health plans to cover chronic disease prevention services before their deductible. So that, a lot of times people will budget with their health care. And so their chronic disease that need to have access to a physician on a regular basis, maybe they're not doing it. Maybe we can keep people healthier longer if they do that. And through prevention, we can prevent a lot of other disease states. I mean, just look for an example for obesity, which is a comorbidity that has huge risk with COVID. And I have a bipartisan bill also that will expand patient access to obesity treatments through drug treatments and provider interventions. So that's kind of the way that we're trying to think and move forward. Terry Sewell just mentioned, Representative Sewell just mentioned about the Rural and Underserved Healthcare Task Force. We've made telehealth one of our priorities because it isn't just for rural, but it's also for other underserved areas. So, how can we expand that? When I was in practice for a long time, especially when you're on call, your telehealth was your phone call. And you didn't bill for that. You took all the calls that came in and you took care of people. It actually got a little bit better when I treat a lot of wounds. Somebody could call and then they could show me a photo of their wound. And, we could do things like FaceTime. And so it makes a big difference. And it certainly makes care much better than having to say, well, you know what, you better come in and see me. So a lot of things that we can do. There's a lot of things that you can't take away from hands-on care. But I've seen some things too. We're talking about expanding to rural areas. Well, when you talk to the internet providers, they say, well, look, it's got to be something that can actually be affordable. Dr. Dorsey mentioned to make it like water and electricity, and really just phone service, I think is something that is in the right line of thinking. But they talk about, well, we have to have so many users per mile. But I have seen the VA, for example, provide access to telehealth in some rural areas by putting a telehealth center inside the American Legion, for example. So maybe we should be looking at how can we at least bring telehealth closer, especially for those that don't, but maybe can get to some building that's in their community that everyone can get to, government building or whatever, and really try to fill this gap, if you will, to allow people to get to telehealth. Patients with Parkinson's, it's not always easy for them to ambulate. And Dr. Dorsey, you know that better than anybody. So I just want your thoughts on some of these barriers that maybe we're facing for telehealth, and whether it's rural or underserved, and what your thought is on the idea of maybe in smaller communities having a telehealth center.
That's an outstanding suggestion, Congressman Winstrup. So we know from the VA experience that they do set up satellite clinics. Some of them are in strip malls. And so you can, for example, if you have PTSD and you're in Oklahoma City, you can go to a clinic there and be seen by a psychiatrist in Dallas, Texas. And I think the experience from the VA tells us something else about telemedicine, is that we don't need artificial licensure restrictions limiting the care that people are receiving. So you serve right outside Cincinnati, Ohio, my hometown, and you can imagine there are people across the river in Kentucky who may not have access to this specialist at the University of Cincinnati, whether that's for pediatrics or for adults. We need to enable Kentuckians and Ohioans and Missourians and Arkansas, I don't know what Arkansas names are, care from any clinician. From any clinician. We've adopted temporary measures in the setting of COVID-19 that have loosened licensure restrictions, and those have worked really well. We should seek to make those permanent and take the example of the VA, which enables any veteran to receive care from any physician participating in the VA, and look at driver's licenses. When you drive across the border of a state, you don't lose the right to use the roads there. We should enable patients to receive care from any participating Medicare clinician.
Right. In Cincinnati, I saw patients from Kentucky, Indiana, whatever. I didn't have to have licenses for those states to see them. And I think it's the same way. I consider if you have access to the doctor and they're in their office and they're in the state where they're licensed, then they're covered. I yield
Thank
back.
you, Doctor.
Thank you.
Thank you very much. Now, Ms. Chu.
Ms. Lilly, while the majority of Medicare beneficiaries are older than 65, there are about 3% who are on Medicare between the ages of 18 and 44 because of their disability, which equates to approximately 920,000, really actually nearly 1 million women of reproductive age on Medicare. We know that most women will use contraception at some point in their lives, and yet, unlike private insurance or Medicaid, Medicare is not required to cover contraception for its beneficiaries. Can you discuss the impacts that this gap in coverage has on beneficiaries with disabilities? Does this lack of coverage hinder beneficiaries with their ability to make decisions about their futures? Are there lessons from the Affordable Care Act's guarantee of cost-free birth control that we could apply to this population?
Happily, because I think this is one of those areas, as I mentioned a little bit earlier, where we designed Medicare not maybe taking into account all of the things that people with disabilities might need on this. There are lots of misconceptions about people with disabilities. It's not just a matter of around kind of coverage of things like contraception, but other sexual health things. And it also extends into other programs where there are penalties against people getting married or penalties against people not the appropriate supports for people with disabilities parenting. There's just this misconception that people with disabilities are not going to have lives like mine, which as a person with a disability can be incredibly frustrating. On your specific question about contraception, that I would say some of those folks are likely to be dual eligible for Medicare and Medicaid, and that somewhat addresses the problem. But it also creates additional barriers because if Medicaid is the payer of last resort, so you have to go to your other health insurance to make sure that they're not going to cover something before you can get Medicaid to cover it. You have to go through an extended process of getting denied, and oftentimes people with disabilities need assistance with that process. So this is a distinct barrier, and I really appreciate you highlighting it.
Thank you so much. Ms. Fisher, thank you for sharing your harrowing story with us. I have constituents in my district who've written to me with similar types of stories as they try to seek treatment and relief for their long COVID symptoms. Some of them contracted COVID early on in the pandemic when tests were scarce and never received a positive test. And we know tests were once hard to come by over the recent holiday season. So can you discuss the challenges that you had trying to get your insurance to cover the necessary tests and treatments for your symptoms?
Yes. Initially it was just difficult finding a test, and so I was able to get that process done. But since then, it's been difficult getting the treatments. When I started developing the tremors, we found a doctor that had an idea to implant a neuromodulation device in my spine, similar to a DBS that they use for Parkinson's, and to kind of calm down my tremors. In that process of getting it approved by insurance, because again, it's never been done before for post-COVID, was very difficult. We had to do a trial process, and it showed significant reduction in the tremor. And so we decided to go ahead with the official implant. So that they denied that, and it had to go through a peer review again. So even though I had found something that had given me the most amount of functionality to then find a permanent solution, the insurance would still deny me.
Well, Dr. Gutierrez, in December of 2020, I sent a letter to America's health insurance companies asking that major insurers stick to their pledges early on in the pandemic that all patients would receive COVID treatment free of charge. Do you think that's happening, or how are long COVID patients able to access care for their symptoms?
This is definitely not happening. They're not accessing long COVID symptom treatments the same way they are for acute COVID treatments. And so we have to go through barriers. We're getting told no by insurance companies. This is inclusive of patients who may have had COVID. The COVID triggered a new autoimmune condition, and that is sometimes even a rare autoimmune condition. And then insurance is not wanting to cover treatment for that.
Thank you. I yield back.
Well, thank you very much. And we have a new member of our subcommittee, Mr. Murphy. We're pleased to have you on board, and you may question next.
Thank you, Chairman Doggett. And let me also especially thank all the witnesses that have come before us. As a practicing physician of 30 years and still a practicing physician, I share a lot of the clinical challenges that you guys are facing, and I also commiserate tremendously with the patient challenges that you guys have had. You know, one thing that did happen, we look at silver linings that perhaps happened during the pandemic, and that was the great thing that telehealth has had. I practice in a very rural aspect of eastern North Carolina, where I still see patients, which I still see, that come from 2 hours north, 2 hours south, and sometimes out on the coast, 5 or 6 hours east. And there is such a detriment, such a impediment rather, for some of those individuals to come. And what COVID did is we know that now 9 million people, because of COVID and the pandemic restrictions, 9 million people did not come in and get cancer screenings. We know so many of these restrictions and the lock-ins and everything else caused such problems with mental health problems, far greater than honestly than should have had. But what we were able to do is take something in telehealth in North Carolina, and I'll give my hat off to the Trump administration because we took away the video requirement for telehealth. I had tried to do that as a state house member in North Carolina and hit wall after wall after wall with insurance companies, as you might imagine. So I think we have a very good opportunity here to continue something that we know is very, very good for patient care and ultimately patient outcomes. Insurance companies don't want to pay for it because why? Actually, patients use it more. They seek the care that they need rather than delaying things and actually exacerbating their conditions and exacerbating what probably is the disease process. So I hope that there will be bipartisan support for us continuing the great advances that we made in telehealth. I would ask this, Mr. Chairman, the government price controls and inclusion quality adjusted life year, the QALY, in the so-called Build Back Better plan would actually, in my opinion, do irrevocable harm to older, disabled, and sicker patients. So, Mr. Chairman, I'm going to ask unanimous consent to enter into the record a letter from the National Council on Disability recommending a quality adjusted life year ban in Build Back Better.
Without objection, it's admitted to our record.
Thank you so very much. You know, I'll go on to commend our clinicians here of the work that they do in trying to treat long COVID. And I understand completely with our patients and our clinicians the burden of getting things pre-authorized because you jump through jump through things that we know as clinicians will be good for our patients, but insurance companies just don't want to pay for them. So I commend you for continuing that fight. Dr. Dorsey, I noticed that you recently went to Camp Lejeune in my district, and thank you for your work there. And I understand you're doing some work in Parkinson's disease amongst our veterans. And I would just ask, do you believe that we're going to be able to really turn the screw a little bit, make a difference clinically with some of our patients using telemedicine, or is this still something really that we need to see and examine really most patients at every visit?
No, you know, hundreds of thousands of individuals with Parkinson's have benefited from telemedicine. We've done 3 randomized controlled trials, all demonstrating its feasibility, all demonstrating comparable clinical outcomes to in-person care, and all demonstrating that immense patient satisfaction. In fact, in some of our studies, patients actually prefer telemedicine to in-person care. And for Camp Lejeune, you know, we should bring justice to the 1 million Marines, their families, and their dependents who served at a Marine base that was knowingly contaminated with trichloroethylene and other industrial chemicals, leading them to have stillborns, cancer, and Parkinson's disease. It's long overdue. The Jerry Ensmiker Act was a step in the right direction, but more needs to be done. for the residents of North Carolina and those that have served.
Great. Well, thank you, Dr. Dorsey. I actually am the lead Republican sponsor on the Camp Lejeune Justice Act that speaks directly to that. I thank you all for this. I hope I thank you, members of the committee, and I just hope that my fellow, members who came to witness and our patients, that I hope that I'll have commitments from the other members of the committee that we fight to make sure that insurance companies, even long after COVID is gone, will cover telehealth because it is best for patient care, and that's why we as clinicians are here. Thank you, Mr. Chairman. With that, I will yield back.
Thank you, Doctor. Mr. Schneider.
Thank you, Mr. Chairman, and I want to thank the subcommittee for having this hearing. I want to thank our witnesses for spending the time with us. You may notice I am speaking to you from my house because I am quarantined, having tested positive for COVID on Monday, or Tuesday, rather, Tuesday. But the good news is I'm vaccinated, boosted, and so far my symptoms are mild, and I'd say that with some anxiety. Ms. Fisher, I want to thank you for bravely sharing your story, and I'm sorry for what you're going through, and I'm wishing you a full recovery. I can only imagine how difficult it is, and what you described, we are seeing across the country. Long-term consequences of COVID are approximately 1 in 10 COVID patients are facing them with lingering effect and impact, and we have to develop policies. As Dr. Murphy mentioned, I don't know that I call it a silver lining. The way I describe it is before the pandemic, the members of the Ways and Means Committee went from supporters of telemedicine to maybe some skeptics. After the experience of COVID, I would say we are all enthusiastic, if not evangelical, about the prospects of telemedicine because we've seen the impact and many of us have personally experienced it. Also, Dr. Dorsey, thank you for the work you do. My uncle Stephen, was diagnosed with Parkinson's more than 40 years ago, has lived with it. He's now 78 years old. I've seen the impact Parkinson's has. I've seen with other family members and friends, people I represent, the impact of chronic disease, the impact of disabilities on the access to healthcare. In fact, in Illinois, 2.3 million individuals, adults, have a disability. 23% of adults living with functional disabilities, difficulties walking, concentrating, deafness, blindness, mental and emotional illness, has the impact on every aspect of daily life. And the access to healthcare is obviously critical in providing that. And so that's why I think it's so important that we're working together. If I want to shift back to COVID though and talk about that for a bit. If I go to Dr. Gutierrez, can you talk about how long COVID is affecting your workforce? And what more can we do to make sure the newest research is available as soon as possible, especially as it relates to workers' compensation? I had a person in my district, a nurse who contracted COVID while working on the front lines, taking care of people in some of the worst moments of the pandemic before vaccines were available, and she's been denied her workers' compensation, in part because there's lack of sufficient research.
Yes, thank you. So definitely, a very big number of my patients are healthcare workers, physicians, nurses, persons who are in the hospital who have to be on the front lines. And for a lot of those patients, they are not being covered by workers' compensation benefits. I do have some patients who are sometimes federal employees, Border Patrol, because I'm in Texas and there's border here. And so but even with them, we have to fight to get the resources and the treatments that they need as well. And so it's difficult if these patients lose their job because of long COVID, then what will they have? It's very costly to be able to get COBRA, especially if you lose your job and you can't pay for those types of benefits. And so we have to ensure that we are taking care of our workforce because they need the treatments, they need the rehabilitation to get them back there. If not, we're already at a shortage. It's going to just be worse.
Yeah, excellent points. I think you talked about the treatments, rehabilitation. For a lot of these people, I imagine I'm grateful that I have very mild symptoms, but for people who lost use of the strength in their legs or their arms. How long might that rehabilitation take before they're able to get hopefully back on their feet and back in the workforce?
It definitely differs for different patients. Some may need a few months, some may need years to be able to get back to the workforce. And they really need multidisciplinary, team-based approach for therapy, vocational rehab, physical therapy, occupational therapy, speech therapy, and that has to be offered for all of them.
Yeah, and I'm running out of time, but what I'm hearing is that it needs to be individualized. Everyone is going to be different. Some will be long stretches, and maybe it will be in fits and starts. But whatever we do, what policies we have to develop, has to recognize and be built on the science and the medicine as we learn about it going forward. Again, I thank everybody. I've extended my time. I yield back.
Thank you for your comments, Mr. Schneider, and for the answers. Mr. Pasquale, I'm pleased you could join us. I made reference to your important Huntington's disease stop the wait measure in my opening statement, and you are welcome to question.
Thank you, Chairman Doggett, for holding what I consider to be, and I know you do, an essential hearing on bridging the gaps to Americans with disabilities and chronic conditions. We know the many barriers to care, but the pandemic has exposed those challenges in stark and unmistakable terms. One of those long-standing barriers is the outrageous waiting period where recipients of Medicare and Social Security disability insurance who qualify for federal disability. I have made it my business to try to get into as many of the special diseases, Mr. Chairman, as possible, because many times they go unattended, unobserved. My bipartisan Huntington's Disease Parity Act would eliminate these unbearable and unnecessary delays for Huntington's disease patients. Huntington's disease is a terminal affliction that causes total physical and mental deterioration. The physical and emotional pain for Huntington sufferers and their loved ones, Mr. Chairman, is truly devastating. Simply put, forcing Huntington's disease patients to wait for care is cruel, in my estimation. They are not alone. I look forward to working with my colleagues on a policy solution for millions of Americans. We must close the insurance and income gaps for people with disabilities and chronic conditions, and I thank you for asking me to join you, and I'm proud of what the committee is doing.
Well, thank you so much, Mr. Pasquale. I believe, are there any other members who are still present who wish to question today? I don't believe we have any others. If not, then I'm glad Mr. Pasquale raises these issues and the importance of our stopping the wait, one of the key issues in this hearing, valuable insights on telemedicine and telehealth, impressive testimony from each of our witnesses, and additional insights from the questions and comments of our members. I think we will take this back to the full committee and hopefully see some action on these important problems. With that, that concludes our hearing, and I bring the subcommittee to a conclusion. Thank you.